I'm to hear Dr. Maha Hilal, one of the most eminent breast radiologists. She is presenting her presentation titled Contrast Enhanced Spectral Digital Mammography. Is it luxury or necessity?
Bismillah ar-Rahman ar-Rahim. Our talk is about contrast enhanced spectral mammography. It is a luxury or necessity. The study was carried out at the National Cancer Institute, Cairo University, using the latest GE digital mammographic system, Xenograph Essential. Potential reasons for inconclusive mammography include dense breast, post-operative breast and treated breasts with irradiation therapy, as both conditions increased breast density, lobular carcinomas and some lesions which are visible on one view and not in the other, and this constitute about 22% of breast lesions, architectural distortions which are also difficult to classify. Signals known to indicate the possibility of cancers are delivered by angiogenesis, which is the growth of new blood vessels that occur around cancers. Contrast agents arrive in tissues affected by these new vessels and can help to visualize these lesions. Modalities like MRI and CT use contrast-enhanced imaging to detect angiogenesis. The idea of this technique is to use the contrast agent in digital mammography to enable visualization of contrast uptake. Contrast-enhanced spectral mammography is a recent development of digital mammography using the intravenous injection of an iodinated or non-ionic contrast agent in conjunction with a spectral mammographic imaging. How does it work? Spectral imaging uses multiple X-ray exposures to reduce the background signal. By suppression of the signal from the normal tissue, the spectral imaging effectively highlights the iodine absorption in the tissues affected by angiogenesis. The examination consists of an intravenous injection of contrast agent, followed by 2 minutes wait before a mammographic examination was carried out in exactly the same positions as a standard screening examination. Contrast-enhanced spectral mammography is approximately in total 20% higher dose than the equivalent in total screening examination. This is the regular kilovolt image, and this is the high kilovolt image. Subtracting the two images from each other, we can get the contrast-enhanced image. So the limitations of this technique include the necessity of compression, because if the compression is not adjusted, it could block the blood flow and limit enhancement. Also, it cannot be used for screening due to the need for contrast medium, adverse consequences of contrast medium. For mass screening, it would be considered high cost and the increased time of examination. Also, it does not provide dynamic information since it's not based on temporal subtraction as in MRI. The advantages of this technique include that it improved all the accuracy measures of conventional mammography. It reduced the time from detection to diagnosis. The information you need is in context you know, so it's easily correlated with mammographic view, easily for technologist and patient acceptance of mammography and potential lower costs than MRI. Applications of this technique include the clarification of equivocal lesions on digital mammography, detection of occult lesions on standard mammography, especially in dense breast, precise determination of the extent of the disease, assessment of tumor recurrence, and monitoring response to chemotherapy. Case presentation. This is a BI-RAD4 right breast mass with obscured margin. After contrast administration, this mass does not enhance except for thin regular rim enhancement, denoting a benign lesion, likely cyst, and this was proved to be a simple cyst by ultrasound. So the contrast mammography reduced the BI-RADS category from 4 to 2. BI-RAD4 right breast lesion in the form of an irregular, ill-defined area of asymmetrical density in the retroareolar region of the breast. After contrast administration, this lesion show thick rim enhancement with non-enhancing center and surrounding reactive enhancement, suggesting an inflammatory process, and this was proved to be an abscess cavity by ultrasound and fine needle aspiration cytology. Malignant looking left breast mass with diffuse edematous changes of the breast. After contrast administration, this lesion was actually composed of two components, a large cystic component with irregular rim enhancement, and a small solid enhancing component showing heterogeneous enhancement. There were multiple rim enhancing nodules seen scattered around the mass, and the pathology of this lesion revealed a signet-ring cell carcinoma. This type of carcinoma is a variant of invasive duct cancer, invasive duct carcinoma. It constitutes about 2% of all breast cancer, and it is uncommon for this type of carcinoma to be multicentric, but this was explained pathologically by the extensive lymphatic permeation. BIRAD4 right breast mass, which after contrast administration, this mass shows strong and heterogeneous enhancement and raising the BIRAD's category from 4 to 5, which was matching with the pathological diagnosis of medullary carcinoma. Dense breast, no definite lesion could be detected. After contrast administration, there were two enhancing, heterogeneously enhancing masses seen in the retroareolar region of the breast, and this was proved to be a multifocal invasive lobular carcinoma. Dense breast with a suspicious mass situated in the upper portion of the right breast. Contrast enhancement was superior to conventional mammography in delineating the extensive tumor mass implicating the upper and the central portion of the breast, and proved to be an invasive duct carcinoma. Another invasive duct carcinoma situated in the retroareolar region of the right breast, showing moderate heterogeneous enhancement after contrast administration, and contrast enhancement was able to detect a small enhancing nodule infiltrating the areolar lip, which was not detected in the conventional mammography. Diffuse edematous changes of the breast, no definite lesion could be detected. Contrast enhancement was able to precisely delineate the tumor burden in the breast, as well as the enhanced metastatic axillary lymph node. Another diffuse edematous changes of the breast, contrast enhancement showed no focal or regional enhancement in the breast, and the diffuse edematous changes was explained by the lymphatic obstruction, which was secondary to axillary lymphadenopathy. Bilateral mirror image invasive lobular carcinoma, conventional mammography suspect a multifocal lesion in the right breast, but the contrast enhancement denied multifocality, as this mass did not enhance after contrast administration and proved by pathology to be a fibroadenoma. In this case of an intraductal carcinoma in situ comedotype, the conventional mammography was superior to the contrast mammography in delineating the extent of the tumor process. The contrast mammography showed a small focal enhancement at the site of the tight clustered microcalcification, which may be correspond to the site of microinvasion. Another in situ carcinoma situated in the lower inner quadrant of the left breast as a focal parenchymal distortion. After contrast administration, this was seen as ductal enhancement. Invasive lobular carcinoma in the upper outer quadrant of the right breast, the contrast mammography was able to detect multifocal lesions. Malignant-looking right breast mass with a large area of increased density close to it, harboring malignant microcalcification. The contrast mammography was amazing in detecting multicentricity in the form of multiple homogeneous and heterogeneous enhancing masses with numerous tiny enhancing foci seen scattered throughout the breast. The other breast of the same patient, the contrast mammography can detect two large cysts in the retroareolar region of the breast with a small enhancing nodule with indistinct margin, and this was proved to be an invasive duct carcinoma pathologically. Patient presented with multiple bone deposits. The conventional mammography suggests a multifocal lesion, but the contrast enhancement can delineate the malignant lesion with two enhancing foci seen anterior to it, not detected in the conventional mammography, and the other masses which were considered malignant in the conventional mammography did not enhance after contrast administration and proved to be fibroadenoma by biopsy. The left breast involuted calcified fibroadenoma did not enhance after contrast administration. Patient with conservative breast surgery 5 years ago was presented with a questionable lesion at the site of the operation. Contrast enhancement can detect a focal enhancing nodule at the lumpectomy bed, and this was proved to be a recurrent invasive duct carcinoma. Recurrent invasive lobular carcinoma at the operative bed and throughout the breast. These are mammograms of patient ending their neoadjuvant chemotherapy. In this particular case, there is a marked discrepancy in tumor size before and after contrast administration, denoting tumor response. In this patient, the mammogram was inconclusive, but the contrast mammography showed a nodular mass situated in the retroareolar region of the breast, denoting no response to chemotherapy. Also in this case, with diffuse edematous changes of the breast and a large ill-defined lesion in the retroareolar region of the breast, there is, after contrast administration, the residual tumor mass was much smaller in size, and also there were areas of breaking down denoting tumor response. Accordingly, we can conclude that contrast-enhanced spectral mammography is a simple way to enhance the detection and characterization of breast lesions, especially in dense breast. With the increasing availability of digital mammography, contrast-enhanced spectral mammography will become accessible and relatively inexpensive compared with current MRI technology. With enough studies made, contrast-enhanced spectral mammography has the potential to prove non-inferiority versus MRI. Thank you.
Thank you so much, Dr. Maha. Any questions?